first of all, just start off talking about your experience at Mission pre-HCA and the work that you did as the hospitals group, to build up that department and kind of your experience with Mission pre-HCA.
Okay. So I came here in '99. At the time, there were 9 members of the practice, and we were providing care primarily for what were the unassigned population, so patients who didn't have a primary care physician or medical contacts in the outpatient community. So people that were either uninsured or were homeless that needed care. That was what we provided for, and we had a contract with the hospital to provide that care. And then heading into the early 2000s, medical practices and the community outpatient practices that were doing both inpatient and outpatient work were in contact with us, asking if we would help, if we would partner with them to do 2 things: to take over the call schedule at the hospital so that we were providing the inpatient call for patients that were being referred from their practice in the emergency room, and also if they could reach out to us if they had a patient in their office that they felt needed to be hospitalized, that we could step in and help with hospitalizing, taking care of those patients. Mm-hmm. So we had practices that we provided full services for, where we admitted, rounded on their patients, took care of them, and then released them back to them at the end. We had practices that we admitted their patients at all hours, but then they came in and rounded on their patients during the day, and then maybe that relationship would evolve over time so that they would turn everything over. And so what happened through the early 2000s is practice after practice began, if it was working well for other practices, they're like, well, maybe this could work well for us as well. And so that necessitated us continuing to grow. And so we grew the practice to, 20 and then 30 and then 40. And then some of the regional areas, the outside counties, those practices that were referring patients in, we would pick those up as part of the unassigned pool of patients as well. So if someone was living in Clay County or in Avery County, whose primary care provider was a long, long way away, if they were outside of the county, we just considered them part of our catchment as well and did that. In the emergency room, volumes continued to grow as well. It's a very busy emergency department. For a while, we were covering it both on the St. Joseph campus and on the Memorial campus until those resources came together. So that's how that was basically the trajectory for what we grew the practice to meet those needs.
And talk about what you saw early on with Mission. You were able to add a lot more folks to that and grow that up. Talk about what that was like pre-HCA, working at Mission, the types of physicians you were able to get in, and kind of that what that was like.
From my perspective, we were recruiting and retaining some of the best physicians in the country. That they were coming from all over the United States, people that wanted to live in Asheville and people that wanted to be a part of what we were building. Turnover was very, very low. If a member moved on to other things once every 3 or 4 years, it was a pretty big deal in our practice. So people that came tended to stay. Most of the members that I had, I'd worked with for decades that were there. So it was a really special experience for me, getting to work with people who I knew had my back and I wanted to have their back. We were accountable to one another. It made for a really good experience. The things that changed, which were multifactorial, were after the transition, people that were leaving because of the loan forgiveness issues that we talked about, or because of prior experiences they'd had with HCA. And under the new contract agreement that the hospital was wanting to have with us, increasingly members were no longer willing to work under those conditions and were beginning to leave for those reasons, which made it more challenging to bring new members on board, because we're a relatively small community as hospitalists, and so word gets out pretty quickly about practices that are thriving versus practices that are beginning to face challenges. I still felt really good about the permanent members that I was recruiting and retaining. It was just getting much harder to bring those members in, and many of those members were much younger members that were just coming right out of training to see us. And my practice, which had a pretty good division between people that were early career, mid-career, and later career, it became more disproportionately people that were coming and staying were early career members. Very good people, and people that I was really proud to work with, but it just changed the dynamic of the practice. And our in our in the footprint that we had with the rest of the medical staff as well. We were becoming a much younger group, and just the way that impacts your relationship with your consultants and with your surgeons and with your ER staff began to change as well.
What were some of the challenges you first noticed after HCA took over? Right. Do you need something, Cody? Or are you good?
No, I'm just trying to fix something.
Right when HCA was first bought the hospital, what did you notice changing first?
So they began to trim some of the non-nursing support staff that was on my unit. So some of the unit secretaries, some of the nursing assistants, some of the other infrastructure that the nurses had. I really needed the nurses that I was working with attending to the immediate medical needs of my patients on the floor, hanging medications on time, doing clinical reassessments, communicating with me regarding changes in the status of my patients. And they had others that were collecting vital signs for them, or checking blood sugars, or making sure that the rooms were kept clean, that their meal trays were coming and going on time, that type of thing. More and more of those duties began getting pushed onto the nurses, sometimes emptying waste baskets, sometimes mopping rooms, sometimes helping with the turnover of a room after a patient was discharged so that another patient that was waiting in the ER could come up. And those aren't really jobs that I think are appropriately assigned to a nurse. The nurse is my partner for providing clinical care for my patient, not for providing for some of those infrastructure needs. But the community became very competitive for some of the housekeeping staff that we had, for example. And so the rates for what you're paying your housekeeping staff need to be competitive with what a hotel is going to pay for them. As you can imagine, the type of work that we ask housekeeping staff to do in our hospital, taking care of patient rooms, is different than taking care of someone who's checking out of a hotel room. The hours of day and night where that work may have to be done, the types of things that you're having to clean up after you discharge a patient from the hospital, all of those things impact the quality of life that staff has too. It seemed that getting patients transported to and from studies, the reliance on the volunteers to help fill gaps, that seemed to become worse and worse. And so as nursing morale began to deteriorate, it has a ripple effect on the morale of the medical staff and the morale of the rest of the staff. So the nurses made the decision to unionize to be able to better defend themselves against some of the encroachments that they were suffering. That also was multifactorial, a lot of upheaval that was going on with the nursing staff with the pandemic and the traveling, that some of the more senior experienced nurses that I, again, had worked with for many, many years were leaving. They were the ones that provided leadership for the rest of the nursing staff and made sure that if there were issues that they could come to us and talk to us about it and we could work it through. A lot of that began to deteriorate, and the relationship with the administration, instead of being collaborative, began to feel, rightly or wrongly, more adversarial, because the things and the issues that we would come to them with weren't being collaboratively addressed. They were, this is what we'll do, this is what we won't do, this is what we'll do, this is what we won't do. And as that began to impact throughput of patients from the emergency room or discharge at the back end, as our discharge planning staff began to exit, we lost the vast majority of our discharge planners during that period of time as well. Their morale became, cratered, and many of them left. I think the community thinks about emergency room services as being, when I come to the emergency room, how long does it take for me to be seen, and how long does it take, if I need to be admitted, to transition from the emergency room up to the floor, and that any issues with that must be the emergency room's fault. But it's not. It's really a whole system of things that have to take place, from not just the emergency services that are being delivered, but at my end, how efficiently am I getting those patients seen and their orders written? How quickly are they being able to be transported up to rooms? Are patients being able to be discharged, or if they need rehabilitation care at another facility, if the discharge planner's been able to coordinate that? Is the housekeeping staff there to turn over the room? If we don't have enough housekeeping staff, even if we have enough of the other staff members, there's going to be some sort of rate-limiting step that's created, because you can't put a patient into a dirty room. And so, I do think that HCA was making substantial efforts to try and address the problems, but the issue for me became they were taking a very reactive stance instead of a proactive stance in addressing nursing morale, in adjusting pay scaling for the housekeeping staff, for providing people incentives to continue to do very difficult work. And it ended up feeling like it was too little too late in a lot of instances. And that became frustrating for people. And so emergency department physicians, hospitalists, psychiatrists, hospice and palliative care staff, surgeons, people from across the spectrum of the medical staff began to reevaluate their options and to decide to move on. And what was equally frustrating for me was that the administration's position when very important people, from my perspective on the medical staff or the nursing staff, were leaving was, well, so what? We'll just have to replace them with somebody else. There was no really sense of loss that they felt when people were leaving, and it helped me begin to understand that they didn't really value those relationships as much as previous administrations that I'd worked under at Mission had, and that began to make me feel like if the work that I'm doing isn't as valued as it once was, maybe it's because I've been doing it too long, or maybe it's because the practice has changed, or maybe because the community and the community's needs have changed, and I need to find another place where the work that I have to offer is valued, and maybe I need to find a place where I can feel like the nurses are valued and that their morale is high. Patient care is much better if nurses are happy. If the nurses are unhappy, nobody's going to be happy. It has such a profound ripple effect through the whole system of care. And it took me a while to get there, but I began to understand more and more the reasons why some of my partners were departing and what was going on. And I came to realize, as the person who was providing leadership for my practice, that maybe I'm part of that problem now. Maybe I have not been able to see the way through to get this problem fixed. And I tried very hard to work my way through and out of the problem, but came to understand that no matter how hard I worked and what I did, that I wasn't going to be able to carry the collaborative influence I'd previously had with the hospital administration, and that maybe it was time for me to move on and to let somebody else come in and to do that. So,
what was it like to see the group that you led? You said you got up to about 60 plus physicians, hospitalists.
In that range, yeah. So between physicians, we have nurse practitioners and physicians assistants that are a part of our practice as well that we worked with.
To go from 60 plus, and then how quickly did that shrink, and what was that like to watch what you had built up go the other direction?
So it was a slow speed train crash. It wasn't that there was a mass exodus of everybody at once. It trickled out, and so the work became trying to use temporary physicians, what we call locum tenens physicians, and others to help fill those gaps so that we could continue to meet service needs while we worked to recruit and hire excellent new members that could join and become a part of the Asheville community. And when we hire physicians in our practice, we want them to put down deep roots in Asheville and to be here for their entire careers. We really want them to be a part of the community and a part of the culture at the hospital and in the community to provide. That's a good way to provide optimum care. The other medical staff outside of our practice get to know us and to trust what we can do and collaborate with us effectively. And it's not an impossible job, but it's very challenging when the rate of turnover became accelerated and high within my own practice, within the emergency room practice. The emergency room physicians are the physician group that we endeavor to have the tightest relationship possible with, because they were the source of the bulk of our referrals. The triage work that they did was absolutely critical to the safe care of our patients, to know who we needed to see first and who needed the most attention the fastest. So we really depended on them. I felt like they really depended on us as well. And when the emergency department began turning over a lot of members and us having to learn that their new members all over again, and they having to do the same thing with us, it caused some challenges in being able to work hand in glove like we always had. I don't know if that makes sense or not.
Yeah, no, it does for sure. When talk about so there were 60 plus in your group, and then you left. You were number 50.
I was number 50 of the physicians that left the practice. I joined, there's 12 of us that are over at the VA, the bulk of whom are working as hospitalists over there as well. Some of them are working in the outpatient clinics as well.
I think for folks at home who may not, a lot of folks don't necessarily understand the hospitalists, and they just think of doctors as doctors and might not know all the ins and outs of these different groups and physicians. But talk about, for a community like Asheville and for Mission Hospital, to go from 60 plus hospitalists down to 10 seems like a huge loss.
So I think the loss was more felt by the group than it was by the community, because our partnership with Team Health allowed us to bring in temporary physicians to fill those gaps. They helped to facilitate the recruiting assets within Team Health were second to none. They were able to bring me large numbers of candidates that I could screen and interview and tour and hire. They provided a lot of infrastructure support that we wouldn't have otherwise had. So we worked. I want the community to understand I did everything I could to avoid any perception that there was a disruption in services, and to keep the turmoil that we were going through as internalized as possible, because I felt it would be devastating for the community to have a bird's eye view of the struggles that we were going through. I was trying very hard to hire as quickly as I was losing, and to, if I couldn't, that I had temporary physicians that Team Health could help me provide to help close those gaps so that patients wouldn't have to wait excessive periods of time to be seen, that we could provide the time that we needed at the bedside with the patients, that the community didn't get the perception that we were rushed or not able to give them our undivided attention when they needed us. So, and I can't know to what extent that was successful or failed. I came to believe over time that I was failing, that I wasn't able to do that in the way that the community needed, and that was part of what was driving the decision that maybe I was beginning to let my members down and maybe let my community down too, and that maybe 23 years is long enough for one person to be in the wheelhouse driving that. Maybe someone with new ideas and new ways of approaching these issues was needed for the group to be ultimately successful, because this group needed to survive me and the members that were here in the very beginning. This is a group that needs to be sustained into perpetuity for the good of the community and for the good of the medical staff. We provide some infrastructure support for the specialists that are in our hospital as well, so that they can be freed up to do the things that only they can really do. And so you were obviously working as hard as you could to replace the folks that were leaving, but as we talked about before, talk about the level of experience though when you're getting people who might be temporary, who might be younger. So I would separate those into two separate groups, because the temporary physicians that we were hiring, like the nurse travelers that were coming, were really placeholders in the practice. They're not able to help us really move the ball forward and to continue to drive and strive for greater and greater excellence in the work that we were doing. They were there to just keep us from not being able to fail in our requirement to meet service needs for the community. The other piece of that is all physicians at some point in their career are early career physicians. I graduated from residency and had to work for the first years of my career as a relatively inexperienced physician, but I was board certified. I checked the boxes in terms of the training that was required to do the work that I was doing, but being a physician is a lifelong experience of learning and growing and adapting and trying to understand the best ways to approach patients who are sick, who are under stress and need help. And the new physicians that I was hiring were no different than I was when I began my work, but a group's maturity and a group's excellence is driven by the relationships that exist within the practice as well. So having people that are intermediate and later career physicians help the younger physicians come along. We model the behavior that is needed so that physicians can continue to mature, that young physicians can feel confident in the work that they're doing because they have somebody that they can turn to if they have questions. Those opportunities get reduced if a disproportionate number of the members of the practice are early career. So I want to make sure that I don't characterize the practice as it exists now as being inferior in any way. It's just different. It's the junior members don't have the same advantages, in my opinion, as a result of most of the intermediate and senior members leaving.
When you talk about your interactions with HCA, when you brought these issues to them of things that you were seeing that were problems, what kind of a response did you get from HCA administration?
So I think they were receptive, and they were willing to hear what I had to say. As time went on, some of the clinical issues that began coming up, developing that they weren't solving to my satisfaction, became increasingly difficult. Patients that we were admitting to the hospital. So a patient that's referred to me by an emergency department physician for consideration of admission, when I go and see that patient, I independently evaluate them, and then I decide, yeah, this patient clearly needs to come into the hospital. They need some around-the-clock care. Or, oh, this is a patient that I think I can treat and release back to their outpatient provider. And the emergency department is essentially asking for a second opinion about whether that patient needs to come in. When I'm trying to think of the best way to describe this. When a patient that I see, I determine to be so sick that they need to be in the hospital, returning them to the waiting room to wait for their bed is unacceptable. Discontinuing patients from drips or from other treatments that I have ordered and putting them in limbo in the waiting room for hours and hours is unacceptable. And when I brought that to the administration when it began happening with patients that I was taking care of, they assured me that that was going to be immediately rectified as an issue of patient safety, but it was not. And whether it was because they could not solve that particular problem or whether they didn't prioritize it in the same way I did and my members were, I can't know. I can't speak for them.
How detrimental is that? I mean, patients in that type of situation could die in the waiting room.
Potentially, yes, or deteriorate and require a different level of care. They may require intensive care unit management instead of floor management at that juncture. So, and we would bring those specific issues when they would arise to the administration. They would pledge to make it better and for it to improve. But instead, what was happening is I was seeing patients increasingly triaged into non-private areas in the emergency department where people were in loungers without dividers between them, having to take very intimate histories or conduct physical examinations in a less than fully private setting. It's very difficult to have patients be able to tell you exactly what's going on if it's within earshot of other patients. When that degree of privacy couldn't be assured anymore, it became increasingly difficult to provide the effective care that many of these patients needed. And I found the community very patient with that to a point. But the issue for me was this was something I had not encountered before in my work as a hospitalist, and it was difficult for me to understand how we couldn't develop the solutions that were needed to provide for patient privacy and patient continuity of care when a patient was referred for admission, when we had always been able to do that previously in our history. My conclusion was it was because we were inadequately resourcing the problem. And the reasons for that not being adequately resourced, I can't speculate as to what they may be, but I just saw that it was impacting the way that my members could provide care for hospitalized patients, and that had a corrosive effect on being able to maintain the integrity of the practice.
Yeah. When you say not enough resources, we've heard there was rooms, there just weren't nurses.
Correct. Yeah, there was. So, and that applies both in the emergency department and up on in the hospital itself. We would have days where we would have vacant beds in the hospital simply because we didn't have enough nurses to staff them. So you can have as many rooms as you want, but unless you've got nurses that can staff them and the infrastructure to be able to support those rooms, you can't put patients in them. And so that became an issue. And in the emergency room, there were extended periods of time where only a fraction of the available emergency room beds were being used for providing emergency services. patients began overflowing into areas of the emergency room where they were waiting for bed space in the area where they needed definitive care. And the availability for the ongoing nursing services that those patients needed was highly variable. So
you talked about the there's a reference to an orange zone, a purple zone. Talk about that if you can, and what a patient we talked to just described the ER situation and the triage situation as just unbelievably different and worse than what it was pre-HCA.
So triage is a chaotic medium to be in as a patient under the best of circumstances. So the red pod in the emergency department was where the ambulance bays initially empty most of their patients, where most of the trauma comes, where patients who have very serious medical conditions, for sepsis, for example, are brought so that the emergency department physicians and nurses there can provide initial stabilization for those patients. So the highest acuity patients are generally there. The other pods are for patients who still need to be seen, but whose level of acuities may not be at that same level. And so ideally, the emergency department triages those patients to those different zones, and so that the level of acuity and the ratios for the staff are appropriately sequenced out. The red zone became an area where essentially everyone was being brought in, not just the hyperacute. And the orange pods and the other pods became overflow areas for patients who we admitted to the hospital, but they didn't have the staffing to bring them upstairs, or they didn't have the bed to bring them upstairs, and they would flow out to those areas. So if you're brought into the hospital with a pneumonia, for example, when I admit you to the hospital, I'm writing for any existing medications you may need, for the new treatments that you may need as a result of having that pneumonia, for your oxygen, for your IV fluids, all of those things. And when those patients are admitted, those treatments are initiated in the emergency department and then continued up on the floors. What I discovered was that some of my patients, when they were going to these other pods, had significant delays in those orders being activated, so patients may not be getting the IV fluids or the insulin or the antibiotics, the things that they needed in those pods. And as a result, I would discover patients who had deteriorated when I reassessed them, and that became problematic. I never believed that to be the emergency department's issue. That's a staffing issue that has to be attended to by the administration of the hospital to make sure that they have the staffing that they need to be able to provide their services. The nurses in the emergency department and the physicians in the emergency department were working extremely hard to meet all of the needs, but their job responsibilities began to expand from not just triaging patients and deciding whether they could be treated and released or had to be triaged and referred for admission, but then they had expanding responsibilities involving patients that were holding in the department that couldn't get to their areas of definitive care, and the physicians that were taking care of those patients then having to come down and round on those patients in the emergency department the following day, where those patients are still on gurneys instead of in hospital beds, may not have had their orders executed in a timely manner, may not be getting the sometimes when patients are sick, they need a lot of attention from their nurse to stay clean, to stay hydrated, to stay well fed. And the emergency department was never designed to provide that level of care to patients. That's what the hospital is for. Everything that's above floor from the emergency department is what's providing for that.
What ended up being the reason that you decided to leave? Was there something that happened, or did it just progress to a level that you decided it was time?
There were a couple of things. As I mentioned before, the working relationship with the emergency department for my practice was absolutely crucial to our success and to our survival. The director of the emergency department and I had a very close working relationship as a consequence, and he decided he was going to step down, that he didn't want to do that job anymore. He didn't have enough control over the processes that were going on in the emergency department or to do those, and he said, I can't do it anymore. And once he decided to do that, I realized that my last remaining clinical partner was not going to do it anymore, and how long would I be able to do this without having that point of contact with the emergency department? I had a a couple of clinical scenarios that also developed in the emergency department. I had a patient in diabetic ketoacidosis, which is a serious health condition that insulin-requiring diabetics can develop when they are sick with other conditions. They require continuous intravenous fluid support and continuous insulin support when that occurs. I had a patient that was disconnected from their treatments and returned to the waiting room until their bed became available without me even being notified that was occurring so that I could intervene. And that patient ended up clinically declining in the waiting room, a very public area, and suffering the indignity of becoming very, very sick, in my opinion, unnecessarily. I had a young asthmatic patient who was also admitted to the hospital and had treatments that were ordered, and inhaled therapies that were needed, intravenous therapies that were needed, and he was returned to his mother into the waiting room and was not brought back to clinical attention, not when I was called to let them know that he was out there, but because he clinically declined and went into respiratory arrest in the waiting room. Now that patient ended up being rescued and being salvaged, but these are near misses that were unacceptable to me, and those were the types of specific examples that I would bring to the administration and to underscore that these were real people that this was happening to. This was somebody's brother, this was somebody's daughter, this was somebody's mom who was depending on us to take care of them at a time when they were very vulnerable, and that we're letting people down when we do these types of things. And I just didn't feel like I didn't feel like I was getting the juice to solve these problems. I was getting a lot of reasons why they couldn't solve them, but it wasn't getting fixed.
Did you fear that one of your patients could die because of this situation?
Very much
and you
so.
would feel at fault, of course.
Very much so. Yeah, that was a grave concern of mine. And also I was concerned with the perspective that our patients, that our community was beginning to have towards living up to the obligation to provide prompt, safe, and effective care for them when they needed us the most. And if we were compromising on those values and weren't meeting those needs any longer, then what would the attitude of the community be regarding the service that we had committed ourselves to provide? Those things meant a great deal to me. The perspective that the way that the community sees my hospital and sees my members and and how they see my nurses, that means a great deal to me. And when I was beginning to get feedback from patients that this wasn't the mission that I used to know, that this wasn't I came to expect more from you or from your nurse, or my room's not clean, my food's not hot. Those types of things make a big difference in how you feel about the work that you're doing, and prompt people to leave if they can't feel like if they don't see an end to that problem. How do I distinguish that from all of the chaos that was associated with how the pandemic infected clinical services? I don't know that I can. I have one perspective on a multifaceted issue, certainly, but those were the things that influenced my decision to leave.
What was it like to work for 23 years for this hospital, really feel like this was your hospital, build up, bring in all these wonderful physicians, and then to watch this happen?
It was devastating for me. It's the biggest failure of my professional career to have gone through that. I was responsible for the practice and for the services that we were going to provide, and I came to understand that I wasn't meeting those needs in the way that I had once been able to, and that I wasn't able to meet the challenge that was in front of me any longer. So it's hard for many professionals to look at themselves honestly in the mirror and to understand that you may have reached the limits on what you can effectively do. But I can't I can't continue to work in that position if I know that my effectiveness is diminished and that what I'm able to provide I'm either incapable of or I can't resource well enough to be able to do.
But you were doing everything you could do, and you were bringing these issues to HCA administration.
Yeah, but sometimes it's just not enough, so you have to take there's some personal responsibility you have to take for failures that occur in a complex system, and those are slow to come sometimes, especially if you're really invested in the work that you're doing. And so, and I can only reflect on my own, personal experience with this. I came to feel that I wasn't able to meet the needs of the community in a way that I once could, that I wasn't meeting the needs of my partners as once I once could, and also from my colleagues outside of my specialty. And that was very hard for me to assimilate and to understand. And I came to believe and to understand that no matter how hard I worked, I wasn't going to be able to work myself out of that problem. There were no more hours in the day. It wasn't a disposable time issue any longer. It was just, there wasn't anything that I felt like I could effectively do to remedy the problem. I didn't have the influence with the administration to affect these changes the way I felt like I once had. And so you have to know when you're beaten and to see if there's somebody else that might be able to bring in a different perspective on that and to be successful, because in the end, what my practice wants is to serve the community and to do the work that needs to be done to make Western North Carolina as healthy as it possibly can be, and to support the mission of our very talented specialists and nurses to be able to provide that care. And if I become ineffective in doing that, then it's a disservice to the community for me to continue in that role. I don't know if that.
Yeah. Do you feel like it's changed at all since you left?
Well, I don't know. I believe that things are trending to improvement. I think my practice is. I think the members that are there are stabilized. There's still some attrition that's taking place, but I don't think it's at the same rate that it was during the last years that I was in the practice. And I want to hope that the trust that the hospital had with the community can be rebuilt. I think that'll take some time. It'll take some effort. It'll take some willingness for the administration to be vulnerable to the community, to do that, and to listen to what the community is saying and to understand their concerns. My interest is in hoping that, and my hope is that that relationship can be less adversarial and more collaborative, both between the community and the HCA, but also between the medical staff and the nursing staff and HCA. But that's a two-way arrangement that they have to do, and I don't know yet whether HCA is ready to hear that or willing to hear that. It's much different than it was under the previous administrations that I worked with.
Do you think the lawsuit will make a difference?
I don't know. It depends on how much the lawsuit inflicts financially on HCA. HCA does not seem terribly invested in its reputation with the community. They seem more interested in providing what they can towards the bottom line for HCA, and as long as that positive flow continues, then they seem nonplussed. If there was a really damaging financial consequence to some of the things that have happened, that could potentially make a difference. But I don't know if anything short of that. I don't know if they really feel vulnerable to the shame that these types of things can bring to the organization. It was not my sense that was really a primary concern for them.
Yeah, perhaps the CMS participation that.
Oh well, that could definitely have a
Yeah.
dramatic effect if CMS disqualified them from Medicare and Medicaid reimbursement. The proportion of patients that fall under those reimbursement systems for Mission is higher than in most health systems, just because of the population of Western North Carolina. Large organizations like HCA are very good at being able to provide the immediate response that's needed to being in immediate jeopardy. The greater challenge is in sustaining those commitments to improvement longitudinally. So the character of an organization is driven by how they behave when nobody's looking, not when they're under inspection. Most people can respond to being under the spotlight and respond appropriately, but how do you respond once the inspectors have left? Do you sustain your commitment to improvement that's been and the needs that have been identified, or do you revert back to other values that may not be as consistent with community need?
Mm-hmm. Right. What's been the hardest part of all this for you?
I miss the men and women that I worked with at Mission on the medical staff and on the nursing staff that I'd had multi-year relationships with. I miss the patients that I took care of at Mission. I just miss a lot of things about that. This was really important work for me. I'm glad that my daughters are grown and were on the path to their own lives before this happened. I'm glad that they didn't have to witness me going through that firsthand, because it was really challenging.
Yeah, and you worked 7 days a week for how many years?
For 3 years, I worked 7 days a week, just trying to hold things together. But like I said before, I was not successful in my efforts, and so.
What was it when you left in January of last year?
Yeah, my last work at Mission was in January of 2023.
And any you kind of mentioned it a little bit, but what hope do you have? What would really make the change here? I mean, do you think there is anything that can be done to fix the issues and revert it back to the old mission?
Yeah, I mean, there's always hope for things to get better. It'll require the medical, nursing, and support staff of Mission to be willing to corroborate again with the administration, and it would take the administration saying and meaning that they want to have that same relationship with the medical and nursing staff, that problem solving requires a collaborative effort, and challenges to find effective solutions to problems. People have to be able to work together. If the relationships become adversarial, that makes problem solving more difficult rather than less difficult.
I think just one other question. For a long time, we heard from the independent monitor, they're holding up their end of the deal. Things are fine. This independent monitor was put in place to make sure that Mission's quality of care was kept at a certain level, and now it feels like we're learning that has not been the case. How hard, I can't imagine, for you to be on the inside during this and seeing this quality of care drop while Mission publicly is saying everything's fine.
Well, I don't know what the reach and depth of the independent monitoring system is under those contracts. That's not something that I would have line of sight on, and what tools they have or don't have to be able to compel change when it's needed. You'd have to ask others about that. I can speak to the board of directors that made the decision about the transition to HCA. I honestly feel we're acting with the best information that they had at the time that they were making their decisions. This was a volunteer board, community members and leaders in our community that were completely invested in providing for the best medical care and surgical care possible for the citizens of Western North Carolina. I knew many of those members. I worked closely with many of those members in my leadership of the practice and in my work with credentials at the hospital. I never had the sense that there was anything but a sincere effort to do the very best they could by the community with this decision. We all make decisions based on the best information that we have at the time, but I really wanted to caution that I had never personally observed, nor do I believe to this day, that any member of the board was doing anything but what they thought was absolutely best, and that they should be held in high regard for the time that they invested into the decision-making process that they went through. And the fact that things haven't worked out the way that it was expected is not a reflection on the integrity of that board. It's just a reflection of the very complex issues that unfold when a for-profit, multi-state entity comes in and takes over a not-for-profit entity in a community where you go from being focused on best care in the community, and it's a very local, decision-based system to being something that becomes a little bit more complicated than that.
I would say the same for your work there as well, though.
So
that you can't, they can't be held at fault, and I don't feel like, you did everything you could as well.
So we'll see. The judgment of the judgment of the community will ultimately come to bear on me. I've been a member of this community for the last 24 years now, and I'm planning on being here for the foreseeable future. And the community and my partners and my colleagues will ultimately have to make their own decisions regarding that based on their interactions with me and the efforts that I made, whether they were effective or ineffective. So I just have to own that part of it and recognize that it's rare that there's just one bad thing that's happening or one bad force that needs to be corrected. It becomes a very complex system of deterioration over time.
Do you feel better in your new role? Do you feel like you are back to doing what you love and have the resources to do that now?
Yeah. I'm very happy in my new work. I'm working with many of my partners that I've worked with for many, many years. There's a significant number of nurses that I worked with at Mission that now work where I'm at the VA, and so we're working to try and to provide the best care possible at the VA, and to take care of our veterans and to take care of their families and to do that. So yeah, it's for me clinically, I'm very happy with the transition, and I do think that it'll be a very nice capstone to my own career to have started as a military physician and to be able to end my career with a focus on taking care of veterans. So yeah, that part will all work out fine.